Today we will be discussing osteochondral lesions. An osteochondral lesion is when a fragment of cartilage at the joint surface separates from the underlying bone. This can happen with repetitive loading, any type of shear forces, or high impact traumatic loading. It can also occur secondary to another injury, such as when the patella subluxes, which means that it dislocates and then relocates, causing a shear force, during an ACL tear, or during a meniscal injury. The potential to heal is decreased due to its poor blood supply to cartilage and can be treated conservatively, but surgical options do exist depending on the severity of the lesion. In a study reviewing 25,124 knee arthroscopies, 60% were found to have chondral lesions. Of those with chondral lesions, 58% were results of non-contact trauma. Athletes are more prone to chondral lesions due to their activity levels and movements performed in sport. Not all lesions are symptomatic. The following is a mock subjective interview for a patient with an osteochondral lesion. Was there a mechanism of injury?
My patella popped in and out of place.
Have you had a previous knee injury in the past?
I tore my ACL a few years ago and I tried to rehab it instead of getting surgery.
What makes your pain worse, and what makes your pain better?
When I walk on it all day, my pain gets worse, and when I get a chance to sit or lay down, it feels better.
Do you experience any locking, clicking, or giving way?
Sometimes I feel like it clicks and it's painful sometimes when I bend my knee. I also feel like my knee isn't as stable as it used to be.
Have you had any imaging done?
My doctor had me get x-rays to check for arthritis, but they came back negative.
Some differential diagnoses for osteochondral lesion include osteoarthritis, ligamentous instability, and a meniscus tear. There is no definitive way clinically to diagnose a lesion. If the PT suspects a lesion secondary to a primary injury, it can be confirmed with an arthroscopy. Some usual symptoms presented are joint effusion, pain, and crepitus. These can also occur with a meniscus tear. There will also be pain and tenderness to the palpation at the site of the lesion. You might also see atrophy of the quad and antalgic gait. Some examinations that you can do on a patient in order to determine whether they have a ligamentous instability, a meniscal tear, or osteoarthritis include Apley's compression and distraction for osteoarthritis and meniscus, as well as McMurray's test for the meniscus. Also, tests for ligamentous instability include Lachman's for the ACL and varus and valgus stress tests for the MCL and LCL. Medical management outside of physical therapy include various surgical procedures, such as debridement, which includes smoothing the joint surface to remove loose bodies. These are typically done for smaller lesions. Reparative microfracture, used by drilling a hole into the bone and allowing the bleeding to clot and therefore heal the lesion. This is also used for smaller lesions. You can do an autologous chondrocyte implantation known as ACI, which takes healthy cartilage from a non-weight-bearing region, cultures it in a lab, and then it is re-injected into the lesion site. This is used mainly with younger patients because they have younger cartilage. Another option is an osteochondral autograft or allograft transfer system, also known as OATS, which takes cartilage from a non-weight-bearing site and replaces it at the site of the lesion. Can also be done as an allograft from a cadaver if the lesion is larger. Physical therapy management post-surgery includes isometrics for the quads, range of motion through pain-free ranges, flexibility, and hip strengthening. At 6 weeks, the therapist can begin mini squats and knee extension if it was not a patellar or a trochlear lesion. At 12 weeks, step-ups and leg press from 0 to 90 may be initiated. Thank you for your time, and I hope you have a great day.